We're halfway through the long-term plan, and as part of that whole review process, especially post-COVID, we now have the Fuller Stocktake. This has been a long-standing review of basically general practice led by Dr. Claire Fuller, and in this episode, we're going to review the report that's just come out that basically and is likely to inform policy in terms of what happens with primary care in the coming months, years, and basically the future for everybody. So let's get cracking in tech enhance your primary care and learning. Hello, GP learners, and welcome to this live stream where we're going to be reviewing the Fuller Stocktake report. And how are we doing, first of all, Andy?
Yeah, I'm doing very well this morning, Gandhi, and hello to all the viewers and listeners out there today. Looking forward to going over this report with you.
Yep. So the Fuller Stocktake is a really pivotal piece of information, I think, in terms of what it's standing for and what it's hopefully going to do. It was commissioned by NHS England as part of as part of Amanda Pritchard, suggesting that there needs to be a review of basically what's happening in general practice. And as part of that, Dr. Claire Fuller, who's one of the, I want to say, ICS commissioning leads in in Heartlands. I've forgotten her official title, and apologies on that. But basically,
Chief Executive Officer of Surrey and Heartlands ICS, I gather.
There we go. It was something in there. But she's basically led on this whole process, and we're going to go through effectively what it's kind of looked like, what they've tried to do to get the information, and then the report itself, which is far-reaching, I think, in its implications. Although, for clarity, it's not a white paper. It's not, an instruction of this is what has to happen. This is what could happen. That's my understanding of it. What do you think of it, Andy?
Yeah, I think we're used to looking at different things here, aren't we? White papers, reports, and so forth. And I think what tends to happen is people commission reports, and those reports are written in a way to try and influence policy. And then the next step is that we get white papers and then actual policy documents that then actually enact those policies or bring them into being. So at this stage, it's what might be a way forwards, I guess. But it's an NHS commissioned report that is intended to inform policy. So I think we do need to take note of it.
Absolutely. And it's going to be interesting to see how this is taken through by the representative organisations that it talks about, and also those that have commissioned it as well. So we're talking about NHS England and stuff. But let's have a little look. So this is the actual report document that we can see. But I think just before we go through the actual document, Andy, if we have a look at the Fuller Stocktake website, so this was how they captured majority of the information. So a real big push to try and include people as best as they could. And this website kind of outlines how they've done that and the various different places and topics they've assessed. So yeah, there's the various different topics there you can see. So living well, communities, remote digital assessment, governance, and all that kind of stuff, and how they've tried to do that. I think there's mentioned somewhere on there they've had 1.5 million Twitter impressions about the Fuller Stocktake in terms of establishing, engagement and stuff. So fairly prolific kind of work and stuff like that. But yeah, we're going to have a look at the actual report. And if you want the links to this, that is down in the description below on the YouTube channel and stuff. So you can follow this with us live on the document if you want. Alternately, obviously, you can feel free to watch it on screen and stuff. But do you want to take us through the document, Andy?
Yeah, definitely. And as we go through, really interested to see what people out there viewing us live think. I know we've got a few viewers watching at the moment. I can see that. So please do comment. And it covers a wide range of issues that are affecting general practice at the moment and have affected general practice over the last few years. So if people want to comment on those individual issues as well, about their local experiences or things that they might like to see nationally or things that they might have liked to have seen in the report that isn't there, then please fire away and we'll bring your comments onto screen and have a look. So it's a nice introduction from Claire Fuller. And as ever with these introductions, people acknowledge the good work that's already been done, and I think that's right and appropriate. She's also acknowledging that there is discontent within primary care, both from patients. I think that's evident in the general mood, I think, that we sense from patients and see in the media, but also from the people that work in primary care, and that's certainly evident as well from my private interactions and from what should we say, medic Twitter and those other places where we see what each other are thinking. And at the heart of that sort of low satisfaction with access is a key theme running through. That's no surprise. And she actually acknowledges that primary care, as we know it, may become unsustainable in a relatively short period of time if we don't address some of these endemic issues, which is quite a bold statement, really. What do you think,
Yeah.
Andy?
Well, I think it recognises that what's currently happening may not be working everywhere, and definitely not working for majority by the sounds of it. We know, and we hear that from our patients. We know, and we hear that from our colleagues, as you mentioned. I think there absolutely is an element of perception in this, in terms of how the media looks at this perspective and how it drives it. And we've talked numerous times how actually often the media highlights the bad and it never comments on the good. It really doesn't like doing that. And as a result of that, that informs the way that people think. And we've talked about how the fact I've had patients in my room who've said they can never get an appointment when they're physically in the room with me having an appointment, and they're still questioning, when a GP's open, when absolutely general practice has been open throughout the entire pandemic, despite what the media say. But I think that there is a shift in terms of what things have happened and how things have happened. And we know there are challenges we have yet to overcome, things like the backlog, things like the fact that our workforce retention rates are dropping significantly, and the fact that, actually we don't have a sustainable workforce for the future of primary care or the NHS itself. And that absolutely needs looking at. And it's really positive to see that this is highlighted at the forefront of the report itself, and that needs addressing, and it has to be addressed from, I think, everyone's perspective. Otherwise, we're just going to have a health system that continues to unfortunately not be suitable for the needs of the population.
Yeah, I think this is quite a realistic look at the challenges facing general practice, including the discontent within the general practice workforce. And I think it's nice to see that reflected in a document commissioned by NHS England, because we don't hear a lot about that. Gandhi, you were talking about the engagement that went into the report, and they sort of acknowledged this within the report itself. And it looks like there has been a really good attempt to engage widely, both on social media, with their website, and going out and having individual sort of conversations with people and practices and round tables and so forth. So that's really encouraging to see, I think, and adds to the credibility of the report. Let's move down. So the other thing is, this isn't just a report about what general practice or primary care, and it is about primary care as well as just general practice itself, should or can do itself. There are a lot of upward recommendations in this report, and we'll see what those are later. But they're just outlining that general practice and primary care networks can't do this on their own. They can't change some of these big issues that have been raised around access and so forth on their own, but they need the input of the wider system. And she makes recommendations of things that the government and NHS England might do to help general practice, which I think is really refreshing. And also acknowledges that you need more, this may require more funding, which we often talk about the underfunding of general practice. So it's good to see that in there, but also that we might need to think differently about how we design services going forwards, which I think is fair. And just highlights also the theme. So these are some themes, I guess, which have come up in the engagement. And she's acknowledging that there's often two things at odds in terms of the access question. And some people have simple problems. Their medical history might be simple, and they want access now, and they don't necessarily mind how they get that, be that telephone, online. They're prepared to be flexible. And there are some patients who are complex, frail, and they really value personalised care and continuity of care. So just acknowledging that these are forces and things that are at odds within general practice.
I think the part that spoke out to me is that the document doesn't highlight what seems to be the running theme that has been for many years, that we just need to increase access. What it actually seems to focus on is improving the experience of access itself. And I think that's an important point from my perspective to look at. Just chucking in more appointments doesn't work. And we've seen that, because no matter how many appointments you provide, it will never be enough. What actually you need to do is improve as it says in the document, improve the experience of those appointments, so then people are getting the right care at the right time. And by doing that, you'll have a much more positive outcome for everybody involved.
Yeah, absolutely. So talks about the vision for integrating primary care, just summarises just some key themes and trends, really. Importance to streamline access, the importance of providing this complex personalised care, and then also about prevention. So really we're looking at the themes of access, personalisation, and continuity, and prevention as well. And those are some themes and threads that run through the report, essentially. So it also talks about aligning leadership, and she's just emphasising that partnership is at the heart of my report. So it's about working together, collaboration, and partnership, and really just highlighting the spirit of that.
I think that's probably somewhere we do need to focus a little bit, Andy, in terms of this whole concept of leadership. We recognise that within primary care in particular, that the leadership aspects needs to be addressed in terms of the structure, and I guess also succession planning. And we see that within practices, don't we? This whole concept of how practices run in terms of the partners leading the practice, and this potentially archaic model of senior partnership, and this view that that's the life goal for everybody and stuff. And whilst it isn't an important part of general practice, it's understanding, is that what people currently still want, and is there different ways of looking at how this will move forward in terms of delivery of the role of the leader, and who should be the leaders, how should you approach the leadership question and stuff. I think that driving forward the fact that locally led leadership is really important, and absolutely, from what I can read from this document, it focuses on the fact that we need to develop better and more enhanced local leadership and stuff.
Yeah, and actually later in the report, it does address some of those questions in more detail. And what I thought was quite helpful is highlighting that developing sort of the leaders of tomorrow would require a combined approach. It's not just down to individual practices to generate the leaders of tomorrow, or individual PCNs, but that actually there should be a partnership between practices, PCNs, GP federations if they exist in the area, health education, organisations. For us, that would be Health Education East Midlands, wouldn't it? In the area, training hubs, or the ICS or the ICB, that everyone really needs to work together and take responsibility for providing and incentivising and equipping with the right training the leaders of tomorrow. And I thought that was important. And also a lot of the report, when you read it, it's quite obvious and quite sensible, really. But these things need to be captured in an appropriate report so that they can then inform government policy. So that was the other thing that struck me in the report. A lot of this, I think, we know this is obvious, a lot of it, but it needs to be captured and it needs to be communicated, because it's not obvious to all the people that will be reading this report as they develop government policy. So, but yeah, leadership is so important, isn't it? Let's continue to move through. So I've just sort of, there's a lot in the report, but I've just picked out some things that I thought were interesting. So that was the introduction. So then we get into the meat and potatoes of the report, really. And first of all, they talk about integrating teams within the neighbourhood. So that's this primary care network level of 30,000 people. And it's just acknowledging, actually, that it's a good validation of this logic around primary care networks. Those of us who've worked in primary care networks for a while, like ourselves, are quite invested, I guess, in it. But she's just sort of acknowledging that she feels there's some logic, in organising teams around this neighbourhood scale, which is nice to see. And it does, from working in that space for a while, it does feel like that is a size of population at which it can be effective. Do you agree, Gandhi? It's a big question, having worked in the area for a while.
Well, I think it allows you to do different things. I think it allows you to do some things that practices at small populations can't do. But I think, it is the direction of travel that we're seeing, this whole investment in primary care networks and that footprint that they cover in terms of being able to deliver care. And it repeats that message throughout this whole document, that actually it is about neighbourhood-led care, and that you need to focus on that level of a population to enable the collaboration and the cooperation to happen, both between services and with patients themselves as well. So, and I think that's one theme we're going to see throughout this. It is, that they are looking at cooperation and collaboration of care to enhance what is currently going on, because that's how they feel this is going to work more effectively. It does also talk about other aspects like place and system, and place being something like 250 to 300,000 population, size and stuff. And then obviously there's the existing 42 ICSs. And I guess one thing we haven't commented on, which is really important to mention, I think. So there's a separate document that comes with this, which is the signed letter by the ICS leads. So all 42 ICS leads have signed up to this report. In terms of basically agreeing that this is the way forward. That's important, I think, and that's a point to note. So the systems seem to be on board with this being the way forward and things, and also it's potentially a way of holding the systems to account potentially in terms of what this will look like moving forward. But yeah, anyway, let's crack on with the
Yeah,
neighbourhood
because there's a
aspect.
lot of implications for wider sort of ICSs. This feels
Hmm.
like a report that's come from general practice, and it's about that kind of bottom level, a bottom
Hmm.
up approach. But there's a lot of recommendations for ICSs, so it's good that they are on board with that. And actually, just here in this section, it's talking about moving secondary care service teams where possible out
Hmm.
towards neighbourhoods, which I think has a lot of implications for some of the other ICS members, like hospital trusts, for example. So
Yep.
that's quite an interesting recommendation. It's not a new one; it's something we've been seeing for a really
No.
long time, but it doesn't happen to the extent that you would hope.
And in particular, later in the document, I can't remember exactly where because it's a reasonable sized document, it's 38 pages and stuff. But it mentions in particular psychiatric services, so mental health services. It mentions in particular pediatric services, and it mentions in particular respiratory based services in terms of care delivery and stuff. So in particular, those aspects of services may need to consider that they need to move towards the community level of care in collaboration with the neighbourhood areas, so basically the PCNs. And geriatrics, elderly frailty, was the other one as well. Sorry.
Yeah, and before people think, where are we going to put all of these people, it does make some comments about estates
Yeah.
as well. We'll get to that in a little while, but that's obviously been a huge challenge for primary care in the last few years, particularly with an expanding primary care
Hmm.
network workforce. It has a lot of these breakout boxes, doesn't it,
Yep.
Gandhi? Which is generally highlighting good practice in areas and actually mainly taking good practice from primary care networks up
Hmm.
and down the country that are relevant to the section of the document that it's in. I'm not I wasn't particularly planning on going into some of these in detail. If there's any that have caught your attention, Gandhi, then draw our attention to it. But they're actually one of the most informative parts of the report, and you can almost, if you're looking for ideas as a primary care network, go through and farm those from the report, as well as looking at the detail of the report itself.
Absolutely. So my first recommendation for any PCN clinical directors looking at this report, go read the breakout boxes. You'll be inspired to see what's happening across the entire country and what could happen if you've got the headspace and the opportunity and the time to deliver these kind of things. So, many of them talk about how networks have adapted roles or changed systems to try and enhance the care and the success that's happened for both their system areas as well as for their patients. Absolutely. So the Healthy Hide one talks about, how they've invested in terms of delivering the more social aspects of the role, so things like the health and wellbeing coaches and the social link workers to drive a healthier environment for their populations and tackle some of the inequalities that they have and how that's had benefits in terms of case finding as well as support for disadvantaged populations and stuff. It's really inspiring stuff, and I must admit, throughout this document, as a PCN clinical director, reading these examples, it just makes you want to think, if I had the time to do this, I would love to do some of this stuff. And those ideas are ticking on that they're coming forward. So fingers crossed, this will help to promote some really excellent changes in care locally, as long as they're supported to happen. But that's the cool thing about this document. That's the one thing I really do like. It enforces the fact that that support needs to happen from the system. This is not general practice that has to do this alone.
Yeah, I think one of my favorite breakout boxes was the one. It's really towards the end of the document where they're talking about inequalities, but it talks about an ICS where they looked at their funding model for general practice, and the
Mhm.
traditional model is based really on raw demographics, like how
Yep.
old people are, and to a certain extent how much disease they have, but not necessarily other markers of inequity and inequality, which we know are huge determinants of health. And they actually reweighted a portion of their funding according to that
Mhm.
and redistributed, which I think is really, really bold.
Yes,
And
that was the Leicestershire area, Rutland. I can't remember
you're
the
probably
exact
right. I can't
footprint
remember
and
which
stuff.
area it was, but I remember the content. I'm sure we'll get to it and
We'll
maybe
get there.
highlight
Yeah.
it over there, because that was really, really important. Now, the next bit I highlighted is worth reading out loud, actually, because this is obviously something that came through loud and clear when they were talking to people. we heard consistently throughout our engagement that a top-down approach of driving change and improvements risks alienating the workforce and communities and hinders development of trusting relationships. That's really been my experience. And COVID's been really mixed, but there's been a lot of top-down things coming out of COVID, particularly I thought in 2021, actually, with winter access funding. And I mean, a lot of it's necessary, isn't it, within kind of diktats on access and so forth. A lot of it's necessary, I guess, within a pandemic situation. But some of those things were really alienating general practice, actually, and taking them off the same page as Department of Health and NHS England.
Yep.
Just acknowledging that those things can be destructive, I think, is important.
Absolutely. I think one of the things that echoes throughout this document is this concept of locally led, nationally supported. It's not directed, not instructed, but supported. So local leadership designs the healthcare that works for their local populations, and that's supported nationally, rather than what we currently seem to have, which is nationally dictated terms that then seem to be either transferred across or interpreted as across, as that's what has to happen absolutely everywhere without any flex or changes based on local situations and stuff. And that's where we're having a disconnect, I think, and massively so in terms of upcoming projects. So we know the network standard hours is the big one for networks and stuff. I think that's one that there is a disconnect in terms of what nationally they're saying and what locally is being interpreted because of the national speak, but we shall see.
Absolutely. And then she just breaks out. So these bullet points are always quite important within the sections because these are sort of the distilled recommendations in the sections. So here she's just highlighting, I believe what my interpretation is that she is highlighting the need to align all the workforce and all the organisations around the neighbourhood footprint as far as possible. Interesting, talking about making available back office and transformation functions like HR and quality improvement, organisational development, data, finance, to actually making those available to PCNs. And my interpretation is not necessarily having PCNs have to do those functions themselves, but being supported by other organisations, which might be other parts of the NHS, like NHS trusts or new supra PCN organisations that sit above PCNs or existing GP federations. I just thought that it was interesting to highlight that specifically that that's something that can be helpful. I know that's something that sort of happens to a certain degree locally, would you say, Gandhi? Yes.
Yeah, absolutely. I think it focuses on the fact that, not neglecting those other organisations around general practice that can support them and primary care networks. So like you mentioned, the federations and other resources to help take on some of those functions. So you're not having to focus as much on the management, because actually what networks should be focusing on is more the development and the patient needs, rather than trying to concern itself with how to sort out back office functions and things.
Yeah, absolutely. Dealing with HR for all the additional workforce can eat a lot of time for primary care networks or lead practices who have taken on the responsibility of employing these people. And then also a shared system-wide approach to estates, including NHS trusts, participation in the system, and recommending a review and co-locating teams and things. So estates, it deals with this in more detail later, but estates has obviously been a huge problem with the implementation and deployment of primary care network, additional roles, reimbursement scheme workforce, for example. And if you're going to have secondary care teams relocated to primary care, it's just going to be impossible without somebody doing something about estates.
So next we've got a breakout box that talks about integrated clinical services, and we're also, if you're looking at streamlining your pharmacy-based services, definitely worth having a look at that example. And it's quite an interesting one in terms of how they've structured their service care and how that's had an improvement, particularly in terms of optimization of medicines for patients, as well as their patient experience and things.
Yeah, this I thought was an interesting section. It's talking about working with people and communities, and they were highlighting a number of things, but in particular that PCNs might work to employ people from the local area, which I thought was a really interesting point, actually. It's something that in our PCN, I think we've moved towards, and it's obviously a really good idea when you think about it with primary care networks, because actually the people who are perhaps best able to understand and engage with a particular population are people from within that population. And it also gives opportunities to people within that population. So it feels like a bit of a no-brainer. Although
Mm.
I'll be interested to know what you think about this, Gandhi. But from the outset, I think we maybe started with a more traditional idea that comes from general practice, which is actually the people you employ shouldn't be registered with your practice. So that
Mm-hmm.
often is just something you're careful of. So I wonder if some of us carried that into primary care network recruiting, at least subconsciously, thinking actually it's going to be difficult if they're from the community because of shared
Yeah.
access to records and things
Mm-hmm.
like that. And perhaps subconsciously just thought about hiring from outside of the community before it dawned on us how useful it is to have people from the community working in the community. I don't know, what did you experience that, Gandhi?
I think we definitely experienced the need for having to look at wider than our current community, but that was more because of availability of workforce rather than necessarily that concept of they shouldn't be working in the area. I'd be keen for our workforce, particularly in terms of network staff, to be from the local area because I think it does inform the knowledge and the experience so much more effectively. But I can understand why potentially that may have not been considered and stuff because actually what you want to tackle is the local health inequalities. Before you scroll down, Andy, if you just go back up, I think there is one point to focus on here because it does mention this important, and it mentions this throughout the document as well. This whole concept of addressing the core 20+5 policy and things. And we're just going to show you what this looks like because I think if you've not come across this before, it may seem a bit daunting. So Andy's put the image on the page, and there's the link if you want to go have a look at it. And it is down below in the show notes as well in terms of having a look at it and stuff. But the core 20+5 is this whole concept of tackling health inequalities in particular. So the core 20 is the 20 percent most deprived population areas based on the IMD criteria. And I've forgotten what IMD stands for, but it's basically the deprivation criteria and things.
Indices of multiple deprivation.
There you go. I
There you
always
go.
forget what it stands for. You've got the plus, which is more targeted elements of stuff that they want to focus on.
Yeah.
And that's for locally derived areas to consider what is important in their local area, in particular in their ICS and stuff. And then the 5 is the key clinical areas of health inequalities that they want addressing. So as you can see there, it splits off into maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension. There are some criteria around those and stuff. But yeah, it's this absolute focus that we need to address that there is health inequalities, and we can't keep just ignoring the fact that they don't exist, and which is unfortunately has happened in the past in some ways. And more importantly, how do the resources reach those areas of health inequalities? Because actually, COVID has shown us massive light on health inequalities, but we haven't been able to address it in the past. And it mentioned, I think, in the past 40 years, it just what's happened hasn't worked. I can't remember where in the document it is, but
Yeah,
it's somewhere
it's
along
like the
those.
document. It's that we've known about the inverse care law. You know, those people who need healthcare the most actually have the worst access to healthcare, the worst
Mhm.
targeted healthcare resources, and we've known about that for 40 years. But very little has changed in terms of health inequalities. And actually, the health inequality and healthy lifespan gap has grown over that
Yeah.
period rather than reduced, which is very sad actually.
Mhm.
It does talk about this. Redistribution thing is talked about later as well, where
Yeah.
it's suggesting that ICSs have discretion in terms of how they target resources, and that they might use this to retarget, redistribute resources towards areas or populations of higher inequality and poorer
Mhm.
health outcomes. So. There we go. Yeah, it's this part I just thought was interesting because it's talking about the system considering sort of outreach activities as so these are activities to go out and mix with and engage with communities about health, just to treat them not as a bolt-on, but actually as a core part of addressing a lot of the
Mhm.
challenges that populations face. And I thought that was interesting because my instincts, again, initially as primary care network clinical director, when I was saying that people like the social link work, social prescribing link workers and clinical pharmacists, other people might go to outreach events to meet the community, I always felt a bit guilty that I was taking them away from a clinic or some
Mhm.
other activity which is more measured, more valued potentially by the system in terms of how we
Mhm.
count to that activity. So it's just really nice to see that outreach is going to be valued as well,
Yeah.
and that it should be valued.
Mhm.
Yeah. Did you feel those same feelings of guilt sometimes, Gandhi, about that.
I think there's a perception that if you're not doing a clinic, then you're not working.
Yeah.
And I think we need to move away from that perception. And we see that across the entire NHS. You know, if I'm not sitting in a room with my GP, then my GP's not working. If my PCN staff are not in clinics seeing patients, then they're not working. And, you know, I think we need to move away from that perspective that people have roles around what they're trying to do. And actually, sometimes the impact that you can see from these can have multiplying effects in terms of what then happens at the coalface when you're seeing patients and stuff. So recognizing that outreach does have an impact, and actually we need to educate people so much more effectively about the healthcare system because it is so much more complex than it was, you know, even 10 years ago, let alone 40 years ago, which many people still harken back to the old model of, I'm going to use your name, Andy, Dr. Foster going around with his visit bag and that kind of stuff, you know, and things. But actually, general practice is not like that. Primary care is not like that. The healthcare system is not like that anymore. You know, education is part of it. And I think the only way you can do that is by outreach in some ways, as well as other support, which it does mention in the document as well.
Yeah, yeah, no, absolutely. The other thing, it introduces this idea of healthcare organisations as anchor organisations, which I thought was quite. It's something I've come across actually on a number of times going to events about primary care networks. But I think it's actually quite important. Do you remember what an anchor organisation is, Gandhi?
No, I can't. So go for it, Andy. Explain
Yeah,
it for us.
this is one thing that really stuck with me. I think I read it from a King's Fund presentation or something like that somewhere. So the idea is that certain in an area there are certain organisations which are like really important for
Mhm.
the success of that area. And people often talk about the schools, and they talk about like also big employers.
Mhm.
If you've got a big employer in that
Yeah.
area. But actually, that healthcare and GP practices should consider themselves anchor organisations as well. And what anchor organisations do are they're an organisation that's there, that's stable, that's probably not going away, that employs local people, and that has the opportunity actually to engage more with the local population. You know, maybe get into schools. You know, encourage aspiration to careers in that area within schools, to drive achievement and attainment in schools. You know, to work with the other anchor organisations together to promote well-being or employment or whatever, you know, their position to promote. And it was quite a powerful thing actually, because I never really thought about GP
Mhm.
surgeries being anchor organisations or important organisations. But I think they are, because they've been there for
Yeah.
often decades and decades and decades, and they do employ local people and they're actually considered really important and part of the community. So
Yep.
um,
And we've
please
seen the impact of when those practices have to close. You know, it's damaging to local populations. It has huge implications for the health and the well-being of those patients, as well as obviously the employment aspects. And particularly, I think in, you know, market towns and that kind of stuff, when they've had to unfortunately face practice closures and stuff, it has a massive impact and stuff.
yeah, absolutely. So just moving through, and as I say, please do pick up and read the document in detail. And I'm sure there's
Mhm.
lots of stuff that is deserving of emphasis that we haven't emphasised. So moving into another question now. Delivering the change our patients and staff want and need. So this is talking about access. So
Yep.
same day access. So they're talking about actually just challenging traditional conventions about what urgent care is and where it happens and what it needs to look like in the future. Acknowledging, this is sort of the introduction to the section really, acknowledging that actually, and I think this is something that we talked about access quite a lot, Gandhi, and I think we've picked up on that actually there's a variety of what people want. You know,
Mhm.
some people want face-to-face, some people love telephone access or online
Yep.
access because it fits with their lifestyle and their profile. You know, if you are younger or you've got a simple health
Mhm.
history and it's something that's new, that's probably, you know, treatable, an acute presentation, then, you know, you'll see anybody anywhere, you know, online, telephone, you just want that sorting out. But if you're
Mhm.
older, frailer, multiple comorbidities, perhaps you have other aspects of your profile that make you more vulnerable, then you're actually going to value continuity and
Mhm.
personalization of that care. So it's just sort of acknowledging that, essentially. Um, there we go. Oh yeah, this was a good example actually.
Mhm.
Foundry Health Care, a single practice PCN. So it's important to note that. So they will have found this easier to do than most PCNs because they are just one big practice.
Mhm.
But they actually streamlined their access model and triage people as being, I think, I forget which way the colours go, but sort of red, I think it was green.
Yeah, so green was your kind of urgent, but not necessarily needing continuity. So things like your minor illnesses, your acute interactions kind of thing. So your MSK stuff, those kind of impacts. You've got your amber that may have chronic disease issues, which value continuity as part of that journey. And then you've got your red, which is your super complex stuff where continuity is an essential part of it, because actually it's the continuity that helps drive the more positive outcome, not necessarily the level of education of the individual, because that's what we know, that that there are time and time again there is research that shows that continuity is the best way of delivering healthcare rather than access and stuff. So it's really important. And one thing I'd love to pick up about this document, this particular box, that mentions. Where is it? They reduced, so the top 5% of frequent attenders used only 30% of the GP consultations, compared with 40% elsewhere. So it's important to focus on the fact that there is this population within every practice, according to this research and stuff and the documents that they've got, that your top 5% of your frequent attenders use approximately 40% of the appointment capacity within a practice. And I think that's something that needs to be acknowledged and recognised, that challenges the way that we can deliver access when you've got a small proportion of patients that have those higher access needs. And actually, that's where you're delivering the most of the healthcare contacts in terms of the practice capacities and stuff. And how do you look at addressing that more effectively? And this practice managed to reduce that by 10%, which is seismic, to be honest. It's that whole concept of compound gains that you have. But really interesting point that I think it mentions about how the perception of access needs to, be addressed really, and how you could do it by looking at different systems.
Yeah, it's good. And they basically, all of their green patients, their simple patients, they sent to one site, and that's what that site did. And then the other sites catered for the other more complicated patients, and that's how they achieved the improvement. And that obviously works in their area, won't work in all areas, but it's certainly worth thinking about. Easier to do when you're a single practice PCN as well. I think
but it raises that question, do we consider different ways of delivering primary care healthcare in terms of that urgent minor illness, acute stuff goes to one site, and the more chronic complex stuff goes to a different place, where that's the host practice and that kind of stuff. And how does that work collaboratively? How does it work with a data protection element of stuff? And it talks about data later on in terms of access and things as well. It's really important that it recognizes those are challenges. But are we moving towards that model, which I think meant some practices out there are going to be really hesitant to consider, because it's a loss of ownership of their populations. And I think the network standard hours contract is going to drive some of this. But it'd be interesting to see how it develops in the future, because actually, are we seeing the setup of this happening through PCNs anyway, potentially?
Yeah, you mentioned the network hours and the extended access. So I was thinking, actually, if you wanted to start to experiment with this, actually, that would be a good sort of separate resource to use as an urgent sort of same day resource and appointments across the primary care network. If a primary care network wanted to start to develop this sort of way of working, because obviously in those appointments, people should be able to be seen at any practice, so it lends itself very much to that urgent access pattern of accessing healthcare. Yeah, it's just acknowledging that there are lots of options, I guess, lots of variety in terms of solutions, and different things will be relevant to different areas. And then also specifically just singling out NHS 111 as kind of a key element of this whole access debate, and that you can't really do anything to improve things without talking about and involving NHS 111 as well. It doesn't really make any further comments or recommendations, but just highlighting that that's an issue. And I know often different parts of the system can have issues with how NHS 111 direct patients. I don't know whether we need to go into that now, but they're often quite cautious, and I don't know, I wonder if people they do a difficult job, don't they? But often people might be directing the cautious way that doesn't make best use of resources.
Yep.
Gandhi's just going to agree with that and side sidestep the issue for the moment, I think.
Otherwise, I think we're going to spiral into various other aspects of things. But I think the reality is that the NHS 111 system doesn't work as effectively as it could do. Is probably all I'm going to leave it as. And
Yeah,
system
but it's a
change.
huge challenge. So it's no,
It is a
it's
huge challenge.
no reflection on them or the people that run it, to be quite honest.
No.
But maybe, and they would probably welcome better integration with the rest of the system as well, because I bet they feel quite isolated and unsupported by other elements of the system, and that they are mopping up for an access issue within general practice and access to emergency departments as well. So yeah, let's all work together on the solution.
Absolutely. And if you are watching it and you do want to comment, feel free to let us know, because we're happy to discuss it if you want to, by letting us know in the comments and stuff. What are your thoughts of NHS 111? And we will happily address that in a few minutes if you want us to. But as we crack on, we're talking about personalised care for people who need it most.
Yeah, so this is the flips. This is the other side of the access issue. So it just talks about urgent access. So and personalised care is almost becoming synonymous with the old continuity concept for me as well. In a lot of these documents, that's what I'm seeing. Personalised care often is very similar to what we would have called continuity of care in the future. And I just picked out a really nice definition of personalised care, which is probably not invented by Claire Fuller here, but let's just read it out. It's what matters to me, not what matters, not what's the matter with me. So it's about what matters to me, not what is a matter with me, which I thought was quite pertinent, actually. Have you come across that definition before, Gandhi?
I've not, so it's quite nice to hear it that way. And when I read that, I was like, yeah, actually, that makes sense. And actually, I think we see that a lot in general practice. Practitioners, hospital-based medicine and general practice to a degree is also set up to exclude the sinister stuff, to exclude the bad stuff. But how well do we address the thing that actually drives the patient to attend, which is, I have a problem and help me fix that problem? We're probably not as good as that as we could be, and I think that's where we're seeing benefits and gains from things like social link prescribers and health and wellbeing coaches, and that's why they're having value in the system itself, because actually they can help address how this stuff impacts me, and maybe we need to reconsider how that offer is looking, and that's a comment to the entire NHS. The NHS is kind of, at the moment, seems to be, well, it is firefighting it, let's be honest, and it's designed to try and just make sure you're not dying or you're not ill, but then that doesn't answer the question of what is wrong necessarily.
Yeah, a really good example for this. I had this conversation in our health forum in our primary care network. So really personal example of this for me recently was sort of dealing with a diabetic who's got some challenges, in life, as well as being a type 1 diabetic. And what matters to the system is what's happening with their HbA1c, primarily, another aspect, the hard measurable aspects of their diabetic control. And that's what's motivating me when I'm talking to him, and I need to get things to certain levels to be satisfied. But what matters to that person was that they're working in a job that they were struggling to do because of their health, and they had financial problems, and they had, all sorts of other problems, which were actually preventing them from achieving these goals, and that actually needed addressing. But I was steered and incentivized to focus on something that he wasn't that bothered about at that point in time. And so it's just nice to see that maybe we're going to be heading in another direction, with another emphasis. Although HbA1c,
in that example, it's important to recognize that you're not actually the person that can fix that. That is our social link workers and stuff, isn't it? That's where those other aspects, and I think that's the part I mentioned earlier about how the fact that the NHS as a whole needs to recognize how it can help patients and help educate them about how we can help them. So, going to see the GP about those aspects of stuff, to be honest, it's not the GP that's going to help that. It's the primary care team of things like your social link workers and health and wellbeing coaches that may help to drive that forward, but it's not the GP individually that's going to be able to fix that.
Yeah, no, absolutely. It talks about other things which are key to personalised care, which we won't go into in detail, but obviously services need to be accessible. We need to respect diversity. Decision making needs to be shared. And that's maybe a discussion for another time. But just highlighting that. So we're talking about, obviously, we need to talk about access and continuity here, but it's talking about bringing investigations, imaging, secondary care to communities. And I thought this was a big issue for estates, and it's a big issue for actually hospital trusts work, another part of the ICS that isn't general practice. Yeah, how do you feel about delivering this aspect of the report, Gandhi? Or
I
delivering
think the estates question is going to be the biggest modifying factor for this, because actually, if you don't have the estates to manage this, then that's a real challenge. It does talk about how prioritizing primary care estates needs to happen now. That actually has probably been a lot of focus on other types of estates, and actually the concept of sharing estates and actually unifying the whole offer needs to be considered, both in terms of, and I think that there's an absolute recognition there are lots of dead spaces potentially available across the areas, but they're not being used because of inbuilt bureaucracy and that kind of stuff. And actually, that just that's a waste. And happy to give an example. In my building where I work, we have a massive health centre, of which only about a quarter of it is actually used, because it's owned by other people within the whole health system, but it's still not used by the health system to its fullest capacity because of internal politics and bureaucracy and various other aspects and stuff. And that's a crying shame, because actually you've got a considerably large estate that is just being wasted.
Yeah, absolutely. It does talk later in the document about the that there are perverse incentives, which it calls it that by name, for all sorts of different organisations that own properties to behave in
Mhm.
ways that are not necessarily conducive to the aims of the overall
Yeah.
system, and it is asking for those to be addressed,
Mhm.
which I think is sensible. It's really good that this report calls out some of those things and highlights them to the people reading the report, who aren't always going to be GPs. They're going to be policymakers as well.
Mhm.
Do you think hospital trusts will be on board with their activities moving out to the community? I think it's going to be complicated how you make that
Yeah.
work business-wise
I think
for.
that's where, and it mentions this, that's where the work across places needs to be more invested in, and those cooperation and collaboration aspects need to be considered as to how you work with each other, because actually that's how you make that happen.
Yeah,
Probably
people
need to
notice
get.
we're skipping over large parts of the report, but we're just highlighting what we think is
Mhm.
key. So the other key theme was preventative healthcare as well, wasn't it? And here, Dr. Fuller is acknowledging that there's a big variation in healthcare and health outcomes in the country, and actually, national averages hide a huge variation, and just highlighting that often those are driven by inequalities, and
Yep.
there can be a 10 plus healthy lifespan difference across between the most affluent and the least affluent areas of the country, and a 15-year plus difference in terms of healthy lifespan, living
Mhm.
without a significant health complication. And then also, this was the bit that you picked up on, Gandhi, but we've had the inverse health law for 40 years. We've known about that, but very little has changed. And in fact,
Mhm.
differences in health have widened. And then also just highlighting the core 20+5, which we talked about previously,
Yep.
as a way of thinking about and addressing some of these inequalities. It's talking about how not just primary care plays a
Mhm.
role in addressing these inequalities, and that was something that always frightened me a little bit about primary care networks, because in the beginning it felt like we were just groups of GPs, and it felt like we were being asked to address all of these huge population health inequalities and differences. I remember sitting in meetings you were in as well, Gandhi, and just
Mhm.
thinking, we can't address these issues. It's just completely out of scope of general practice. I think it was, but the report's highlighting that actually it's the responsibility of all of the partners in a neighbourhood and in a wider area,
Mhm.
including community assets like pharmacists. I mentioned dentists a few times in this report. I've almost stopped thinking about dentists as part of the NHS. But that's another debate entirely, isn't it? But
Yeah, well, unfortunately, their contract is pushing many of them away from providing NHS dentistry. Several friends with dentists who are just simply turning around saying, well, the current contract means that they can't deliver care, so they're just going private. Downside to that is, in areas of health inequalities where deprivation is a key part of that, no dental care.
dentists, absolutely.
Yeah.
You've got to travel further and further for dental care if you can get it at all. But anyway, yeah. So it's just saying that actually this is and should be a responsibility of a wider community of providers, and that actually there is a role for national campaigns as well. And we've had some
Mhm.
good national campaigns recently, but I think we've also seen a pullback on spending on other health campaigns, like smoking, for example, and so forth. So just highlighting that. And there's the voluntary, charitable, social organisations as well play a factor. So just thought that was worth highlighting. We can't do it on our own, and we should never be expected to. And it just highlights just 3 key areas as well, and just broadly to call them out and highlight them. It's just early years and children's services, particularly immunisations. It talks about cancer diagnoses, and you can see how these are actually sort of pulled from some of those core 20+5s, and it also talks about positive lifestyle choices and engaging with screening programs as well, more widely outside of the cancer area. And the trick for ICSs is to normalise this behaviour. So it's talking about ICSs being involved in just normalise the behaviour of all of these organisations collaborating, working together, looking at data, sharing, and then intervening in population health. So ICS is to create, I guess, the environment where that is normal and that happens. It's increasingly happening, but it's not been a normal part of general practice for most of the time I've been working in it, I would say. And then we begin to talk about providing ICS, again, at place level ICSs, providing the skills, resources, highlighting data there, because often we need data experts, and they're only really going to be employable at that ICS level. And also just sharing good practice across an ICS area as well. As we scroll. Okay, so get towards the latter stages of the document now, where the recommendations start to go upwards a little bit. So creating the national environment to support the locally driven change. So she highlights here that neighbourhoods and even places, that's not enough. They alone cannot address all of the problems faced by primary care in the population, and they can't make primary care sustainable themselves. We need a policy environment and a national approach and attitude that is supportive to the locally driven change that's needed. So I think that's really
picks on these 3 key areas of workforce, estates, and data that need to be addressed and stuff. So I think we're going to move down and have a look at those.
Yeah, and that's what's addressed in these areas, really. So workforce. So thought about actually confronting workforce gaps. So she spends a number of paragraphs actually just highlighting and justifying and demonstrating that there aren't enough GPs, essentially. Makes the recommendation, and we're familiar with a lot of the figures that I think that she quotes, and just actually we need as many GPs as we can possibly get. So she's saying, we're not going to address this with the additional hours workforce. They are very, very welcome, and they are key to achieving a lot of these population health outcomes and the other outcomes, but we need GPs as well. So as a GP, it's nice to see that acknowledged.
Absolutely. I think it's worth going just a little bit deeper into this. One of the key parts that I like, and I can't remember exactly where it is on this page, but it is somewhere on here, the fact that there is a false perception that general practice numbers are actually improving. And she identifies this clearly because the number of people qualifying is masking the actual level of experience and knowledge that exists within the GP workforce. Although the numbers are going up, many more of those newer GPs are not working full time because of the demands and the workload capacity issues that are there. But also increasingly, we're seeing an increased amount of experienced GPs reducing the amount of time that they're working or retiring. And that's losing the experience and the value and the opportunity that they bring to the GP workforce as a result of it. And both of those aspects need to be addressed, because if not, we are going to have a massive deficit outside of the pending the retirement time bomb that they're anticipating in terms of things, as well as supporting our IMG colleagues who are trained in this country to remain in this country, because actually, a lot of the wider issues in terms of diversity are forcing them out. And we've seen some of that already in the past few weeks, how, an IMG colleague has been basically suspended by the GMC for requesting a laptop. And the miscommunications that seem to have happened in that case. Now, that's obviously an ongoing case, and it's now even being reviewed because there's been such a public outcry over that. But it just goes to show the experience that many IMGs are having, and actually that needs to be addressed as well. And it's really nice to see Dr. Fuller take target on these issues, that actually it's not just numbers like many people like to comment on. It's the quality, it's also the experience that needs to be addressed as well.
Yeah, no, absolutely. She also makes the point, she says, but the workforce picture in primary care is not all bleak. So she acknowledges that actually there's a huge number, multiple thousands of new people employed in primary care through the primary care network additional roles reimbursement scheme. And she also just again acknowledges, for those people who have missed that the NHS is committed to funding those posts beyond the end of the initial primary care network dead in 2024. So it's just further acknowledgement of that.
And also recognising there needs to be a plan for what happens after 2024 as well, in terms of the support and supervision of those roles, because that part is not clear. And obviously that's going to have a massive impact in terms of retaining those staff, because if people we don't know, then they're going to start leaving. Duh.
Absolutely true. I mean, actually, yeah, because they're guaranteeing those roles, aren't they? The funding for those roles. But what about the funding for practices to supervise those roles and for the management infrastructure provided by primary care networks through the £1.50 and the 176 practices?
Which again has led to the less availability of GPs, because actually all these roles are being told they have to be supervised by GPs, and actually if they're supervising people, then they're not seeing people.
Nonetheless, new funding, new roles, new people in general practice, and that's positive. So that's good. But she's also saying actually there's variation in how well those have been recruited in areas, so how many of those there are in different areas across the country, and the success with which they're being used to impact patient care and patient health. And just highlights that there are a number of factors, including the availability of local leadership, management capacity locally, and estates as well, which is one of the main ones that I hear a lot about. So she also talks about systems working differently to shape their workforce. So highlighting the role of the ICS here, and I just thought it's just mentioning demedicalising care and help as well, which I just thought was important, because we're becoming increasingly involved in people's care, and there's a danger that everything becomes medicalised. So I just thought that was nice to see that sentence there. Encouragement for ICSs to share staff, encourage the sharing of staff across organisations, and rotating staff around, which I thought was nice ideas. I've heard them before, but it's good ideas. Would you have a consultant come out and shadow you as a GP, for example? I think that's the sort of thing she's talking about.
So open invitation to any of my NUH colleagues. If you want to come and see what life is like in general practice, you're more than welcome to.
And you're very welcome to come to my surgery as well. Be interesting, and maybe we should spend more time in the hospital as well. Maybe that's different to how we remembered it. I think we think at least we spent.
I've done that. We've had that exchange scheme run before in Nottingham pre-COVID, and I know that they're looking at rebooting that as well. But yep, I've been to renal clinics, for example. Had a great opportunity to see the experience from their side. But absolutely would offer that invitation back to our secondary care colleagues to come and see what life is like in general practice.
Yeah, good. And further on workforce, extending the agenda beyond headcount, which I think is a bit like you were saying before. Really, it's about what they're doing and how effective they are, and actually sometimes, whilst they're not seeing patients, they're doing other useful things like supervising colleagues or providing training to colleagues, and so forth. And in particular, she's talking about from the attracting people side. We need to make sure that these roles are attractive to work in, with realistic work-life balance and working conditions and variety of work, and so forth. I mean, that's something I've often found can be a challenge, or something that needs a bit of headspace given to when thinking about retaining primary care network staff, for example, because there's a lot of competition to recruit them. All primary care networks for these roles, and if they're doing something that is not rewarding for them, then it can be difficult to retain them. So so that's just a microcosm of the need within the system, I guess, to make sure that roles are attractive and to think about the workforce, not just the numbers, but about them as people, and are they trained and are they fulfilled? So I think that's important. And they further emphasise the need for training all roles, and they're mentioning receptionists as well as more senior roles, and they're also talking about training for mid and later career people as well, to keep refreshing training throughout their time. And then also, I think we touched on this earlier, talking about actually a joined up thinking to support the workforce
Mm.
and make sure we've got the leaders there and the people that we need in the future, and that actually ICSs need to work together with the primary care networks, the local training hubs, Health Education England, leadership academies, just all together in a more joined up way to make sure that we have the people we need for the posts that we need them in, including leadership. It's very, very sensible recommendations, really. We need to listen and support frontline staff, and this just talks about really just listening, whistleblower, right to speak up, valuing diversity, tackling harassment, all those things which they always feel like they, you start to think, you maybe don't need to say them every time, but they are so important, and you do need to state them. Gandhi, you're just cringing at me there. It's just
It's just the fact that, like you say, we have
more.
to keep repeating this stuff because
Yeah.
it still happens, and it's a shame that that's the case, but unfortunately, it has to be repeated because
it's important that it needs to be in the documents because it remains important. No matter if we think we've made progress in these areas, actually, you come across examples where we clearly haven't, so they need to be emphasised. Investing in local leadership to drive change. I think we spoke about this somewhat already. I don't know if there was any new bits within this section. There's the 3 bullet points which might be worth addressing, Andy.
I think, it's about focusing about the needs around your local area and what does that succession planning look like? What does that development of, who your future leaders are going to be? But also supporting the current ones as well to make sure that they've got the capacity and the ability to move forward, rather than being disenchanted by the whole prospect of what they're being asked to do. I know we're doing that, aren't we, to a degree, Andy, with the PCM Plus course that we've developed to try and support CDs across the whole patch, because actually there's not a great deal of stuff that's specifically designed for clinical directors to help them understand how to do the roles. But it is wider than clinical directors within your networks themselves. Many networks now get to the size where they're having to develop leadership within their networks in terms of the roles or how the teams are working and stuff. So having that key prospect that actually people can be leaders and supporting them and encourage them from any part of general practice is really important and stuff. And we'll hopefully have better opportunities for the future as well, rather than everyone just kind of thinking, nah, somebody else will do it.
Absolutely. And you're right. So leaders from different parts of general practice in the system. So there's an emphasis on multi-professional leadership as well.
Absolutely.
And about growing the next clinical director. Actually, you need leaders throughout the system, including in our admin and our reception teams and our other clinical teams, people to act in a leadership capacity within those teams. And they can be more effective if you actually support them to be leaders and give them appropriate training. So it's really good to see that.
I think that message needs to be echoed as well to NHS England. Obviously, when the original DES contracts came out, they pretty much said that only a GP could be a clinical director. We have seen expansion of that to include other roles, which is really important. But it's taken a lot of pressure and challenge to back to them to say, actually, these can change. And, my network has a nurse as a co-clinical director with myself, and it's a really important perspective that brings value to the role and stuff. So, we are seeing other areas where there are clinical directors, where they're pharmacists, where they're PAs, that kind of stuff. And I think it's important to understand that people bring value not just because of the role that they have, but because of the experience that they have as well, and not to discount that.
Yeah. And the next section, this is a big one, estates. So I mean, it is a huge problem, and it's nice to see it highlighted and done so, I think, in quite an effective way for the audience of this report. Some interesting stats, actually, just as she gives just a brief overview of the general practice estate. 22% of the estates were built pre-1948, which I think was that astonishes me. So there's still a lot of converted, probably extended and improved, Victorian properties, in use as general practices. Nearly 50% owned by GP surgeries, which is a lot. 35% owned by other companies. That's becoming increasingly popular as people often sell to a specific company that then leases back to general practice, which just highlights how complicated the general practice estates ownership structure can be. And then 14% are owned by NHS Property Services, which is owned by the Department of Health itself, I gather.
Which in itself has some challenges, as we've talked about on numerous occasions.
It does. You'd think they'd be really, really good landlords to deal with, wouldn't you, Gandhi? It can be really problematic. Yeah. So yeah, and there's some issues around, some of this. So a lot of this data is old, needs improving. There's not much of it, and I think she's sort of hinting that the ownership structure can provide some perverse incentives. I'm not quite sure who she's got in the crosshairs for that. Whether it's perverse incentives for the 49% GPs that own their own properties, or whether it's some of the third-party owners. It's maybe a bit of everybody, but I think she's implying that can impair the I don't know, comfort with which the Department of Health might invest in estates, and that we need to find a way to get over and get past that, because there simply is not enough estate, and it is not of sufficient quality to deliver the vision set out by this document, but already articulated in other policy papers, essentially. Did you have anything else to say on that first bit of estates, Gandhi?
No, I think we've covered it all. I'm mindful of time, as well as saying something I'm going to probably regret. I think we're going to move on.
Let's move on. She also highlighted that there's a lot of focus on capital investment in secondary care estates, shiny new hospital rather than GP surgery. So, I mean, there was quite a lot of investment in lift buildings, wasn't there? Which I think is where NHS Property Services came into being. So we've got quite a lot of shiny buildings, but that's over 10 years ago now that wave of building happened. So okay, estates. Interesting. So sensible estates suggestions involve developing primary care estate plans from the perspective of access and population health and health inequalities. So that those will be key components of developing estate strategies. Making use of third sector and local authority community assets. So that's really sensible, isn't it? And we had a bit of experience of that in COVID, didn't we? Using council properties or shared ownership properties for vaccination centres or assessment centres. So kind of building on a lot of that work. Emphasis on co-locating primary care with secondary care estates plan, as the secondary care look to be compelled to bring some resources out into neighbourhoods to coordinate that, which makes sense. But that's more resource for estates to make appropriate estates available. Pragmatic low-cost opportunities to repurpose existing space. So I guess looking for vacant space in areas. So did you say that there was about 50% of your healthcare capacity in your building vacant? So maybe it's finding a pragmatic solution to bring that.
I think there's also that concept of co-locating other services within practice as well. In areas of high deprivation, for example, having financial support services co-located in the practice. That's where the need is. So actually, you mentioned the patient who you were having to focus on the medical aspect, but actually what they needed support with was the financial aspect. And actually, if you could then say, well, we've dealt with your medical stuff here, we know that this impacts your health in terms of financial issues. Why don't you go speak to the financial team who are based just over the road, just the other side of the corridor? Actually, that person's going to have a much more positive experience and a more better chance of being able to move forward in their patient journey, rather than, go to see the financial support team who live on the other side of the city that costs you 5 buses to get across with. And, actually, you don't have that money to do it in the first place. So you're not even going to be able to do it.
Yeah, no, the number of times I've said, you should go and see the Citizens Advice Bureau. They're near the train station in Nottingham City Centre, which I know it's going to be hard for you to get there, but that's where they are. So yeah, that's absolutely very true. And then finally, it just talks about opportunities of locating primary care on the high street. So they're talking about really just moving primary care right to where patients go as well. And it's saying as part of local economic regeneration. So it's probably a nod to, maybe there's a lot of vacant high street shops at the moment, as they've been doing so well recently, which, and it's sensible. And sometimes, there's opportunity in adversity, isn't there? So, gosh, this is a long one this morning, Gandhi, but we'll keep going. Maybe people can probably use the tabs to navigate to where they want within the show.
So do check, probably worth checking out. We should have mentioned this at the start. We'll put timestamps and stuff down in the show notes. You can jump around and stuff to the relevant parts once we've processed the episode. Data.
So it's really highlighting the need for interoperability and access across all the teams to a reliable, up-to-date patient record that they can write into and out of, which sounds very, very sensible, but all too often isn't there yet within the NHS. So it talks about that. I mean, we talk about that quite a lot, Gandhi. It highlights the need. There's all sorts of reasons why that isn't the case, and efforts to put that in place in the future. Anything succinct to say on that yourself?
I think the key thing is it talks about the challenges of data, and that there's a massive element of fear that comes with this as well in terms of getting it wrong. And it mentions somewhere in this part, and I've lost track of where it is, that actually, the GDPR aspects of changes that came into effect a few years ago have had such a profound effect in how general practice shares data that actually that responsibility may not necessarily need to be on the individual practices. That there needs to be incorporation of that, understanding that some aspects of that are not for the practices to bear in terms of complications and challenges, and actually that there needs to be an open attitude taken towards data. We know that data, when it's done well, can really help inform the prospects in terms of demand, in terms of patient care, in terms of collaborative care, in terms of any aspects of care. But the data needs to be accurate, and the data needs to be shown in a way that's made easy to interpret and stuff. But the sharing aspect is often the thing that blocks a lot of the development and the interoperation. And actually, a lot of that is just because somebody thinks that's the way it has to be. And actually, there are really good solutions that exist to fix a lot of that. And actually, sometimes it's ingrained in us now that you can't share data because of the risk of a breach and stuff. But do we need to think more openly and honestly about this and actually learn from other places and how to do it? And there's some examples there in terms of System P in Cheshire and that kind of stuff and things. But I think, um, data is really important because good quality data makes you more effective at delivering care. And I think one of the things it does mention somewhere in there is about the data about demand. But actually, if you can move forward in terms of understanding the demand element more effectively, and particularly the hidden demand that we don't see, general practice is really good at seeing the stuff that they see. But there's a huge proportion, I suspect, of stuff we don't see because we know that patients say, I ring up at 8 o'clock in the morning, I can't get through. How are we going to deal with that?
Yeah, absolutely. And that's the other part that she talks about here, about the need for easily accessible real-time data on demand, activity, capacity, all of these things. And I know we're trying to move in that direction, and we just need to continue that and get it right, really, because if you
The key
actually know
thing with
what
that data, that responsibility should not be on the practice to develop and deliver that data because it's beyond their abilities to do so. That requires system level involvement. And I think that's one of the key things about this. It is about system level support, national level support to lead locally.
Absolutely. I mean, that's the section of the document we're in. So all of these are system and national level pleas, really, for support and for them to take responsibility of these things. It also talks later, somewhere in this section, about developing local chief information officers and chief clinical information
Yep.
officers in areas who I think would really be helpful in terms of taking a lot of those high level calls on what's acceptable, what isn't, and holding responsibility for those decisions, which would help individual practices and lower level partners not live in fear of the Information Commissioner's office when they're thinking about data sharing. So and then it talks about making the right IT infrastructure decisions, which are difficult. There's a track record of making wrong decisions, in the country, isn't there? And a lot of good decisions will have been made as well that we never talk about because they've gone well. But that's interesting. And sort of taking decisions at an ICS level about infrastructure sort of purchases so that there's an equity of offer across primary care and organisations. I've got mixed feelings about that because I think often you get kind of a healthy ecosystem of providers that compete with one another and innovate, where general practice is able to make individual purchasing decisions. Although I appreciate that then there's an inequity of the offer. So maybe a system with kind of minimum standards, but that leaves space for innovation would be something I would advocate rather than blanket place level decisions about the purchase of absolutely everything digital wide. But she's more, I think, placing emphasis on place level decisions about this. I don't know if you've got any thoughts on that, Andy.
I think, like you say, there needs to be variety because no one solution will fit every opportunity. And I think the prospect of what that looks like needs to be addressed. I think there does need to be selection, and actually the NHS digital strategy does say that as well. There needs to be options available to meet the needs of both sides of the population, whether that's the practice-based population delivering the care, whether that's the patient-based population receiving the care, as well as an element, for the providers of that, which is often, well, it was the CCGs, it's whatever it's going to be moving forward in terms of the structure of the ICS moving forward. But we do need variety. No one system will fit every situation and things. It's important to always keep that at the forefront and stuff.
So we've had a comment from Ankish Patel.
Should we come back to that later? So it's Anish K. Patel.
Anish. I
Yeah.
thought it might be.
Can I suggest we come
our
towards
local
at the end, if that's all right? Because I think that's going to be a good one to sum up on.
Okay, yeah, that'll help us summarise, won't it?
Mhm.
Just continue to move through data. Really, I think we've covered some of these points. Really, talking about the ICS's role in procurement and setting the data environment. And I think they absolutely have a role, but we just don't want to lose that ability to innovate and have an ecosystem of innovative providers. So hardwiring the system to support change. So this is really just the summary, and then it takes each individual area that we've already talked about in terms of what the system needs to do around workforce, estates, and data and digital, and then returns to those areas of access and capacity that we visited earlier. So I've made some comments here, but they're really just highlighting things that were made before, I think. How do you want to handle this part of the document, Gandhi? I know you'd had a look at the summary.
I think if people do want to have a read of it's a 38-page document. This is probably the focus area for most people who want the summary. It's not really at the front. This is the executive summary, should we say, this part onwards and stuff. So definitely worth having a look at. I think if you scroll down a little bit, Andy, we made reference to this particular point about targeting the resources that need to happen. So it's the case example, which is in the box. So that's the Leicestershire, Rutland one about focusing financial support to those places of need. And how they've apportioned that and things. But it does, mention how you can do that, and also it reinforces this concept of backing existing models of, as well as new models of primary care, and what that may mean moving forward and things for different areas and different places, because everywhere is different. And that's the important thing to remember. General practice can never be a universal offer because the populations you serve are not universally the same. And I think that's one of the key messages I would take from a lot of this stuff. After this comes a brief forward from postword, from Dr. Claire Fuller in terms of conclusions and things. But then there is a table of summary of actions effectively in the annex, and that's Annex A and stuff that's worth having a look at. And I think we will probably do a separate briefer episode that just focuses on the annex itself in terms of.
We'll scroll down to there in a moment, but I want to just give it just a small bit of emphasis to just this area where she talks about backing existing practices as well as new models of care, and that this isn't about replacing GP practices that are established and working well, which I think is very welcome to acknowledge. Shall we go to the annex and just have a look at the summary, Gandhi? Unless there's anything we're skimming over that you feel we need to give emphasis. I'm aware we're at 1 hour 20 minutes. So although actually a number of people have stayed with us throughout the whole thing, which is really, really admirable. Shall we go to the annex and table and then just wrap up and maybe answer?
So I think we'll just show you the annex itself. So this is the framework for a shared action that it mentions, and it basically apportions the different points it mentions and who's responsible for them. So it does apportion some of this responsibility, for example, to NHS England, some of it to the ICSs in terms of what needs to happen. As I said, I think we're probably going to do a separate element of a briefer review that focuses on this particular thing, but it's worth having a look at, and particularly for those system leaders, this is probably the part you need to focus on the most, to be honest, because it outlines very clearly this should happen by this organization, this part of the system and things, and how that needs to look and feel. And I think, again, it is then signed off by the people involved in this, but there is that separate letter when you go to the links that shows you the letters signed up by the ICS organisation leads themselves, the 42 ICS leads. And I'm going to suggest we wrap up by looking at Anish's comment, if that's all right, Andy. So I'm going to get rid of the screen share and things. So Anish has asked the question, can't really tell from the way you guys have spoken about this one. Are you feeling positive about this, or the same old thing, as in they're not going to listen and it's like you're shouting into a pillow? What do you think, Andy?
Can't tell whether we're feeling positive. That's probably because it's been an hour and 20 minutes of the document. I'm feeling positive about the content of the document. I say a lot of it isn't new to me. You know, these are things which I've heard spoken about in different places a lot over the last few years. I guess what is new is that they are in a report that is commissioned by NHS England and the Department of Health. So they have commissioned the report. They will read it. They've commissioned it with the intention of it informing policy. And actually, I think it's written in a way that actually frames sensible suggestions within the framework of what the Department of Health and NHS England already have put in motion in terms of ICSs, primary care networks and neighbourhoods. So I think there is a likelihood that a number of the comments will be put into place, I think. A lot of emphasis is placed on a national framework that enables a place to make this happen. So I think there's a lot of responsibility going to be placed on place, and I think place will have a difficult job enabling or implementing a lot of this, particularly around those key areas of estates in particular, and the shifting of activity from secondary care out to primary care. So I think it's going to be challenging. I think overall this will move us in the right direction, I think, and hopefully it will win over and change the views of some people at the Department of Health who, through their actions, seem to have other views about primary care. So I am positive, and I think we'll see some change as a result of it, and I think it moves in the right direction, but it won't solve all of our problems. Okay, what do you think?
I'd echo a lot of those comments. I think one of the key things that I'm mindful of is so this report is one of the largest kind of exploration views that they've taken, looking at what needs to happen with the NHS, and you know, often we've commented that there needs to be a debate about healthcare in terms of what do people actually want. Now, this isn't that debate. This isn't a debate about NHS, but this is a debate about primary care, and I think it does highlight some of the key changes that need to happen in some ways. And we've agreed with quite a few of these in principle in terms of what they need to look like. So we know that workforce needs challenging and tackling. We know the estates element needs looking at significantly. So we know that data needs looking at, which is, you know, the Stocktake does take recognition of and how that needs to change. It does recognise positive improvement of care, and it does also recognise there are areas of improvement and stuff. But the key thing that I'm going to come back to is that this has been signed by the 42 ICS leads. Okay. So the people in charge of each ICS has agreed that in principle, they agree with everything that's in this document. And that's the part that I think needs to happen now moving forward. So all those system leaders need to recognize that the ICSs need to take forward the primary care voice that is within this document and instilled within this document that primary care is part of the journey of the ICSs, and that needs to be there. That voice needs to be heard. And if it's not being heard, if it's not instilled within that structure of the ICS, then actually this is the one that you need to show in front of everybody saying, but you need to. And here's the information that shows you why you need to. Because actually, if you don't, this is where the problems are going to come. So, you know, as the ICSs have now formed and are due to kick off in the imminent future, you know, if primary care representation, if primary care voice is not within that ICS, this is what you need to push in front of them and say that if you're not doing this, because this is what NHS England now need to look at. And they've said that they will look at it. And, you know, what's the point in commissioning a massive report if you're not going to take note of the information it is? You know, unless in case your name is Boris Johnson, then to be honest, yeah, you should be listening to the bit information you've commissioned.
Careful, Gandhi. So on that note, so hopefully we've answered Anish's question there. I think we're both sort of a little bit optimistic, but realistically cynical, but optimistic. I'm optimistic.
The information is there to move forward. How people take it is then the next question. But important to recognise this is not a policy document. This is a supportive, it's a stock take. It's understanding the situation and what the options are moving forward. Last thing
So,
I'm going to say is the absence of something, though. So one thing I did notice, there is absolutely no mention of the RCGP in this document. There is absolutely no mention of the BMA or the GPC in this document whatsoever. So important to recognise that there are some parties that haven't been mentioned in this particular. In fact, I lie. The RCGP is mentioned in the document as one of the reference points in the in the references and stuff. But I think that's more work done by the RCGP. It's important to recognise that aspect as well, that not all parties are actually included in this, and that may be something to kind of comment on.
Yes, interesting. Something we've observed happening more and more of late. So I guess on that note, that brings us to the end. Hopefully this was useful. It's been a long one, hasn't it, Gandhi? But it is a really interesting and quite significant document, and people can visit the bits that they want using the show notes and the tabbed areas.
Absolutely.
So, anything to say before we wrap up?
No, as ever, if you've got any comments or questions, let us know. We're more than keen to hear about them. And if you do want to do so, do feel free to use our SpeakPipe opportunity, where you can speak directly to us and tell us what you're thinking and stuff. We'd be more than keen to hear from you. The link to that is www.speakpipe.com/EGP learning, and the G and the P are capital. Everything else can be lowercase and stuff. Additionally, we are, as ever, here to try and support you in primary care. We love doing all this content. We've got more stuff coming for you in the near future. And as always, we will be here to help tech enhance your primary care and learning. And we will catch you next episode.
See you guys.